This is presentation number 7 in GIT series, concerned with imaging of bariatric surgery, prepared by Dr. Maher Hassoud and revised by Prof. Sharaf. We have three types of operations mainly: 0NY bypass, the adjustable banding, and laparoscopic sleeve gastrectomy. We have fluoroscopy of the upper GIT using water-soluble contrast, and we have abdominal computed tomography. Both are essential to detect the potential complications, which are leakage, stricture, marginal ulceration, ischemia, internal herniation, small bowel obstruction, intussusception, and recurrent weight gain. The jejunum in row and Y operations is divided 25 to 50 centimeter distal to the ligament of treats, and the distal limb, the raw limb or efferent limb, that is that one, is brought up and anastomoed to the gastric pouch by means of an end-to-end or end-to-side, either anterior or posterior to the transverse colon, and sometimes we need a window in the transverse mesocolon if we are doing it posterior, and then a stable line here partitions the stomach into small fundus and a large excluded part. So we have small fundus. This is a new stomach. This is the excluded stomach. All of this with its loop and proximal jejunum. So a much larger excluded stomach is seen. The jejunal row Y limb, this one, rolling, is joined proximally to the fundus via a gastrojejunal anastomosis. This is the one, either as we said end-to-end or end-to-side, anterior or posterior to the transverse colon. Distally, we have the biliopancreatic limb still, this part. So distally it is anastomosed here. There is another anastomosis here via the jejunal anastomosis. So this is a new jejunum put into the jejunum. This is jejunal anastomosis. This limb is now important for biliary and pancreatic juices to be transmitted to the intestine. When obtaining the upper GI study in patients with row and Y gastric bypass, it is important to follow the head of the colon or contrast material at fluoroscopy as it passes from the esophagus into the gastric pouch, and then from the gastric pouch to the first limb via the gastrojejunal anastomosis. There may be a short segment of circumferential narrowing as it traverses this region. The gastric pouch is typically appearing on the upper GIT as a small structure with a volume of 15 to 20 milliliter. The gastrojejunal anastomosis should be visualized in profile without overlap between the gastric pouch and the jejunum. This is important to provide a reasonable estimate of the anastomotic diameter. When the jejunum is connected to the inferior aspect of the pouch, The gastrojejunal anastomosis is readily visualized on frontal views. If it is from the lower margin, it is easily to be seen in the LB view. But when the jejunum is connected to the anterior or posterior parts of the pouch, steep, oblique, or lateral views are needed to show the anastomosis in profile. Contrast material should pass freely into the raw limb. The study is not completed until the small bowel is ossified down beyond the jejunostomy done or the jejunal anastomosis so could be assessed. So we have supine spot image from the single contrast upper GI study. Shows the ossified gastric pouch here with the barium entering in the row Y, that is the part from the stomach, and the blind end jejunum, white arrows, small part, blind end. This denotes widely patent side-to-side jejunostomy. Here, all of these are side-to-side, big, long side-to-side anastomosis between jejunum and jejunum to allow the drainage of the pancreatic and the biliary excretions. Gaseous distension of small bowel loops resulted from aerophagia. The excluded stomach, the rest of the stomach should be here. The excluded should be visualized on CT and is normally collapsed. Cannot be seen here, of course, but it is a complete part of this. This is a pouch, and the stomach should be completing this area like that. This all to be seen in the CT as collapsed part. This is the excluded stomach. This is the small gastric pouch filled with contrast, and this is the jejunal loop anastomosed. So normal appearance of raw and wide gastric bypass at CT. An axial CT image after oral and intravenous contrast is made. Shows small gastric pouch B separated by the stable line. This is the stable line, this one, this dense part here, metallic part, dense part here. Separate from the excluded stomach, the pouch, excluded stomach, and the step line here. Jejunal row and Y, J, this is the jejunal row limb, which is anastomosed to the gastric pouch and is continuous. With it, the excluded stomach appears collapsed and non-ossified. Here, row and Y gastric bypass with post-operative anastomotic leak. Supine spot image from upper GI examination with water-soluble contrast material shows the focal extravasation from the left lateral aspect of the gastrojejunal anastomosis into two short tracts. So contrast is coming from the anastomotic side into up and down, two short tracts, and adjoining the extraliminal collection. This all is extraliminal collection. All of this is extraliminal. So this is the drainage tube, and this is another drainage tube. So this is the extravasated contrast, and this is the leaking part, and this is another leaking part, and this is the anastomosis between the pouch of the stomach and the jejunum. Contrast material is then passing through and around the drain, the arrowhead. This is the drain, and contrast is seeping around. That communicates with the inferior aspect of this collection. This is the inferior aspect of the collection, and the drainage is coming out. To understand this image again, pouch, jejunum, anastomosis, leakage, collecting in a space, and then drained by this tube with another collection here. Row-NY gastric bypass with post-operative anastomosis, anastomotic leak. Again, after oral but not intravenous contrast material. Axial CT scan shows extravasate contrast material in the perisplenic area. This is the perisplenic area, and this is the contrast around, indicating post-operative leakage. Jejunal row limb more medially. This is the jejunal row limb, and this is a stable line, and the region of the stomach, and the region of the excluded of the pancreas, and this is the region of the pancreas. Spleen. It is around the spleen. Here is around the spleen. Perisplenic collection. Row-NY bypass gastric bypass with anastomotic extraction. Here it is. This is the steep right posterior oblique. This is the right oblique position from single contrast given. This is a gastro-jejunal anastomosis. In profile, enabling visualization of right anastomotic structure. This is the structure. This structure was not visible in supine position, as in supine you will find all of this overlap each other, and it will overlap the lower gastric pouch and the upper end of jejunal loop, so will obscure this anastomosis. So any effort should be done, or all effort should be done to do it on profile to show the anastomotic site, and if a narrowing, should be elucidated. This is the appearance of a gastro-jejunal ulcer, marginal ulcer, in row-NY gastric bypass with a supine right posterior oblique spot image. So still we are doing obliquity and giving single contrast, and this shows a ulcer niche, big ulcer niche, abutting the gastrojejunal anastomotic site at the region of the gastrojejunal anastomotic site. Of course, this will result in abdominal pain and melena. Row-NY gastric bypass operation with obstruction, now showing jejunal row limb dilated. Now CT scan, axial CT images after oral and intravenous contrast material administration show dilated gastric pouch. This is the excluded stomach collapsed, and this is the gastric pouch, and then a big jejunal loop, very dilated, extending into dilated gastric pouch P, and mainly dilated jejunal limb extending in the left mid-abdomen, this one and that one. With abrupt transition due to obstruction at the jejunal anastomosis. Here the normal is collapsed, and here the dilated, so there is dilatation here. Of course, the excluded stomach is collapsed. So here there is definite obstruction of the jejunal loop. Row-NY gastric bypass was obstructing internal hernia. Axial CT image after oral and not intravenous contrast material administration show a collapsed gastric pouch. Collapsed gastric pouch P, this area, and excluded stomach. This is the excluded stomach. Dilated crystal small bowel loops. There are some dilated small bowel loops displaced into the left upper quadrant. This is the jejunum, dilated jejunum. It is still displaced into the left upper quadrant here with these arrows around. So this is the displaced part of the small intestine of the jejunum, the raw limb, denoting small intestinal obstruction. Where are these? This is a paraduodenal hernia. Paraduodenal hernia. Internal herniation. Overhead radiograph from small bowel follow through in the same patient, also to show the cluster dilated displaced small bowel loops in the left upper quadrant. This is the one, this group, and the excluded stomach region. Excluded stomach and duodenum are opacified as a result of retrograde flow in the jejunal anastomosis because there is herniation. Row and gastric bypass with breakdown of the stable line. The stable line should be between that pouch and the stomach. So supine spot image from single contrast barium shows focal disruption of the proximal end of the stable line, with barium passing from the gastric pouch laterally into excluded stomach. Via the gastric fistula. You remember that between the pouch of the stomach, which is connected afterwards to the jejunum, there is excluded stomach. This should be excluded. Now one of the staples here is broken, it's not there. There is interruption of the staple line, so barium comes into the excluded stomach. So simple. This is the rest of the pouch, and this is the gastrojejunal anastomosis. Gastrojejunal anastomosis. So again, esophagus, pouch, jejunum. From this upper end, from the upper end of this pouch, there is break of the stable line. So barium comes into the excluded stomach. Now laparoscopic adjustable gastric banding, small gastric pouch, banded and port over under the skin, and this one is excluded. Not excluded, it is banded, so only a small amount of food can pass. Adjustable silicone gastric band is placed around the stomach about 2 cm below the gastroesophageal junction to create a small gastric pouch above the band. The band is sutured to the adjacent wall of the stomach to decrease the chances of band slippage. The band has an inflatable inner sleeve that is connected via tubing to subcutaneous port in the right, or less commonly the left abdominal wall. Subcutaneous. It's not for the patient, it is for the doctor only. This configuration enables adjustment of the band by altering the amount of fluid within the band via a needle inserted into subcutaneous port. So we can increase the amount of bending or decrease the amount or release the bending by fluid from the port. The normal diameter of the gastric pouch is usually about 4 cm, corresponding to a volume of 15 to 20 milliliters. Normal imaging features: upper GI examination. After placement of the gastric band, an upper GI examination may be performed with an oral Administer total solute to confirm the location of the band in relation to the stomach, assessing the caliber of the lumen of the band, and to evaluate the post-operative leakage. A scout image should be obtained to document the location of the band, which normally has an oblique orientation with its lateral side above its medial side, just beneath the medial aspect of the left hemidiaphragm. Never mind about all of this, it's just to make oblique view to show well the band and the port. Here is the location of the band, frontal or slightly right posterior oblique, showing the bands. This one is repeated after this one. They give 1 centimeter, they remove 1 centimeter of saline to show only mild narrowing of the lumen. So repeat study after removal 1 milliliter. When you remove fluid from the band, you make it smaller, thus it appears smaller as here, and this would produce more narrowing. On CT, the opaque band can be identified around the abdominal stomach, and the attached tubing can be seen extending through the peritoneal space and rectus before connecting to the subcutaneous port along the anterior rectus sheath. All components of the device and the adjacent soft tissue should be assessed. CT may be helpful in evaluating for the source of infection and assessing soft tissue changes. You have to see the band, you have to see the line, the tube, and you have to see the port. This is the band. Expected appearance of the band at CT. After oral and intravenous contrast, administration shows the band device arrowhead, the black one. The positioned around the proximal stomach, the band connected via tube. This is a tube to any injectable port, to an injectable port in this area. Complications of the laparoscopic adjustable gastric building include stomal stenosis, is the most common, malposition, pouch dilatation, band slippage, perforation, gastric volvulus, and intraluminal band erosion. Distal band slippage with obstruction. Upright scout image of the upper abdomen shows abnormal position of the band, black arrow. Shouldn't be like that, should be oriented like, should not be oriented like that. It's located more inferior than expected. Also note the air fluid level within the gastric pouch. It is away. Upright frontal spot image from single contrast shows marked narrowing and high-grade obstruction of the lumen. The lumen is not passing any fluid, any barium, and this is caused by the slipped band with markedly dilated gastric pouch above. This obstruction leads to removal of all the fluid, resolved. This obstruction is resolved after removal of all the fluid from the band, so deflate the band. Distal band slippage. The band can be slipped down, and supine spot film from single contrast examination marked distal slippage of the band with converging gastric mucosal folds due to twisting. High-grade obstruction with no barium entering into the stomach. Distal to the band. This is the arrow, small arrow here. Nothing is coming down. The mucosa is converging to the region of the band, and there is too much dilatation above but nothing below. Gastric band partially eroding the gastric lumen, so it is coming inside after oral intravenous contrast, which was aspect of the band device has eroded into the lumen of the stomach. Shouldn't go inside. Should not be dilated by barium from inside. Gastric band completely eroding the gastric lumen with partial obstruction. Lateral spot image shows barium completely surrounding the band, which has migrated to the cardia and is caused partial obstruction with dilated fluid esophagus. So slippage of the band and eroding of the band. We have now two main terms: slippage and eroding of the lumen of the stomach. This is laparoscopic sleeve gastrectomy, in which the stomach is resected along the greater curve body and proximal antrum, producing a narrow banana-shaped stomach. This is the one. This is a new one, and this will be removed. Sleeve gastrectomy is performed by laparoscopic dividing the stomach along its long axis, producing a narrow banana-shaped gastric pouch along the lesser curve. The remaining stomach has residual volume of only about 100 milliliter, causing the patient to experience early weight loss, and it is irreversible. Typically reveal the upper GI examination typically reveal a long tubular structure with maybe a small pouch at the beginning. Because of the distal gastric antrum is preserved, there may be a small another pouch at the end. Some patients may have both upper pouch and lower pouch, and that linear structure, which is now acting as a stomach. Normal finding after sleeve supine fill single contrast shows tubular narrow stomach. This is a tubular narrow stomach, secondary resection of the greater curve. Sometimes you can find a small pouch here and a small pouch there. So we have tubular stomach, superior pouch, inferior pouch, or maybe both pouches. Here is the stomach, the new one, deconstructed stomach with small dilatation above or some dilatation below. CT by performed may be performed after laparoscopic sleeve gastrectomy to assess for abscess, perforation, and of course the most common complication is abscess formation. CT typically revealed a narrow tubular stomach that has smaller caliber along its long axis. A stable line is typically identified along the greater curve of the residual stomach. This is the stable line. Small caliber tubular stomach. This is a new stomach. The complications after sleeve include postoperative leakage, strictures, abscess formation, gastric dilatation, and gastroesophageal reflux. So please don't forget that the most important here is leakage, and of course will result in leakage will result in abscess and associated gastroesophageal reflux. Our gastric lesions are potential concerns after laparoscopic sleeve gastrectomy, because the length of the stable line along the greater curve is lengthy. However, post-operative leakage have been reported. Less than 1% of these patients are affected. Individuals typically present with pain, fever, leukocytosis. Leaks most commonly occur from the proximal end of the stable line, at the proximal end, where the trauma of food is always experienced, and sometimes you will find extravasation into the left upper quadrant. So this will be the condition. Here is the stomach, and S is the gastric sleeve, and this is the site of leakage, and this is a collection at the left upper quadrant. So site of leakage, stomach, and collection. This is another tubular stomach we should have in sleeve gastrectomy. Narrowed tubular stomach, narrowed tubular stomach with leakage usually in the left upper quadrant. Of course there is leakage here. And where is the stomach? The stomach is a tubular structure here. External collection C. There is gas shadow with extravasated material. This is all extravasation. This is fluid, and this is the oral contrast. So oral contrast with fluid is delineating here, and at the same time gas is formed at the region of leakage, and this is the small stomach reconstructed. Stomach, small, mildly dilated esophagus above. This is acceptable, and this is the pouch down, and this is leakage. This one is leakage. This one is leakage. This one big is leakage. So leakage can be variable, either small or medium or large according to the how long is there. Now post-operative air fluid level collection adjacent to this what is delineated here is the stomach, reconstructed stomach, the stable line, and this is an abscess, typically an abscess. Usually the abscess is adjacent to the spleen, usually. Here it is, superior pouch resembling leakage, but it is smooth line and not continuous to any. Here on the left you have a small pouch with irregular upper contour, small pouch with narrow neck in the middle, and small bowl with an irregular outer contour again. So different shapes, but no extension into definite spaces, and it is at the site where the proximal end of the stomach is. So can resemble leakage, but follow it and check for any extension into the peritoneum. Gastric strictures and gastric outlet obstructions. Some patients develop symptoms of gastric outlet obstruction when scarring along the greater curved stable line causes marked narrowing of the pouch. Bariatric revealed focal strictures. Here's like that. This is a strictured segment distal to the stomach above is definitely dilated. Abscess formation usually, of course, presents with symptoms and abdominal pain, fever, and vomiting. Literal clinical suspicion if there is CT scan. I mean, if there is clinical suspicion, you should go to CT scan and do. And this is an extensive abscess formation, but this is a very gastric abscess in the suture line anterior to the left lobe of the liver. Usually this occur at or near to the spleen. Usually it occurs near to the spleen. This is a usual site of abscess formation adjacent to the stable line of the stomach and near to the spleen. This is the usual site. Thank you.